Hi, everybody. This is Aisling. We're going to get into evaluation of practice at the population level today. The objectives for this module are that the students should be able to describe ways to evaluate population outcomes, identify population-based models of care delivery, and name 4 indicators nurses can use to measure quality of population health nursing delivery. There is kind of a clear progression of this through the chapter, and I just think this is an opportunity to elucidate some of the themes of the chapter. I found the chapter was a little dense. I think I mentioned this during our last lecture that it's hard when a textbook is written, each chapter written by different authors, because it makes it very difficult for them to have cohesion. So there is a fair amount of repetition between chapters, and so I'm not going to focus on those things that we've covered already, but just sort of highlight the new concepts and key concepts that you should be paying attention to for the purposes of working through the quiz. Speaking of which, I want to let you know I'm going to give everybody more time for the quiz, this next quiz that we have, and actually I'm going to be changing the dates of the quiz because realizing that with the holiday last weekend, I think it may be a little bit premature to expect you guys to be getting through those 5 chapters. So I'm going to add a week into the syllabus, and I'll make an announcement so that everybody's aware. But for our purposes, this is covering chapter 8. So we've got another lecture that will cover chapter 9 and 10 collectively next week, and then the quiz will be the following week, will be available for a week, and the time of the quiz will be 2 hours rather than 1 hour. So just wanted to give you that update. So let's get into it. In the population health model, quality is defined in terms of clinical data and outcomes, both economic and patient-centered. Pretty early on in the chapter, they do discuss sort of the different models and how quality assurance has evolved over time, both in the industrial sphere as well as in the medical sphere, and how medicine and nursing adopted some of those key tenets that were developed through industry, as we've discussed in previous lectures. The way that it's been adapted for nursing is to really focus on quality, understanding that for nursing, the categories that we focus on are clinical quality, customer satisfaction, core business processes, and utilization of healthcare resources. So we're going to get to that, but the first part of the chapter really does focus on how we've kind of adopted and adapted some of the quality assurance methodologies that were developed by Joseph Jurin and Donna Bedian, as we've spoken about before, and some of the organizations that we've been talking about, the National Quality Forum and the Institute for Healthcare Improvement. The idea being that if quality improves, the cost should resultingly go down. I think that you guys delved into some of this in your second discussion post, and I was really, taken with some of the discussion about how this ends up playing out in the clinical spheres in which you guys operate as practitioners of nursing, and seeing up close like what works well and what is also challenging in trying to put what looks good on paper into practice, and that the element of the human element is always at work there and can complicate what seems like a pretty easy quality improvement process. So quality is defined in terms of clinical data and outcomes, these outcomes being both economic and patient-centered, so that we can track side by side not only cost, but also patient outcomes in terms of their clinical success, ability to adhere to a plan of care and resolve medical issues, but also their satisfaction with the experience of going through a treatment plan. Population health is centered in prevention, screening, and patient self-care management. So as opposed to being centered in treatment, the idea of population health is to avoid problems before they become problems by equipping patients and their families with access and having them be well-informed participants in their own healthcare, so that they can pick up issues rather than having to rely on isolated clinical encounters with providers who may not know them that well. So the idea of population health being a very holistic model. So some of the measures of quality that we look to in population health are listed here. The value of these measures are that they encompass a great deal of data, and so therefore you can stratify them by geography, by patient type, by population characteristics, and have a better idea of not only the needs of a population, but also how well interventions will succeed among that population. So these are HEDIS, the Healthcare Effectiveness Data and Information Set, which is part of the CMS. The CMS Medicare and Medicaid Services 5-star quality rating system measures, accountable care organizations, national quality forums, never events, the fact that now we don't pay for avoidable infections, hospital-acquired infections, nosocomial infections, that health insurance companies look at these very seriously and base payment off of them rather than just accepting, and that the NQF National Quality Forum has put together a list of never events. In the text, it describes the stage 4 pressure ulcers, that a pressure ulcer is an avoidable condition, manageable, and is an indicator of poor quality. And then the National Patient Safety Goals. IHI's triple aim, and I really would encourage you guys to check out IHI and sign up for their listserv. I think I've mentioned this to you in the past. The triple aim initiative is focused on improving health, improving the experience of care that patients have, and lowering cost. And this idea that cost is consistently following the quality of patient care in an inverse relationship. So cost goes down as patient quality goes up because providers are anticipating problems rather than reacting to them, is borne out in the data. See, I want to make sure that I'm not forgetting anything on this. And I apologize for that buzzing. My dryer is going as we speak. This is a quote from Juran. Joseph Juran was he actually started out in the complaints department, I think in a telephone company in one of the Bell companies, whether it was Bell Atlantic or Southwestern Bell, but he got kind of inducted into working and got a lot of training, was given a lot of training in quality assurance methods very early when, they were just kind of being piloted. And out of the work that he did as he became kind of ensconced in a mindset of quality assurance, he was sent to Japan to learn to teach them about quality improvement mechanisms and systems after World War II, and he was very involved, after that, like kind of on an ongoing basis. So when we think of like the automotive industry and how the United States learned from Japan's recovery after World War II and building up their the automation of their automobile industry, a lot of really key aspects of quality improvement and quality assurance and quality control were developed during that time in the automotive industry, and then were adapted into the healthcare industry. And one of the tenets, this quote kind of points to is the importance of the entire organization being involved. This is also mentioned when they were talking in the chapter about Six Sigma lean processes, that if it's just one department or one floor of a hospital or one office of a managed care organization that's doing a quality assurance or quality improvement process, it's not going to be sustainable. It really is critical that the entire organization adopt quality improvement processes. And this quote, "It is most important that top management be quality minded. In the absence of sincere manifestation of interest at the top, little will happen below." And I think that, as nurses, we probably have seen this borne out again and again, that if the management at the top aren't buying into the importance of focusing on quality, or they're just giving it lip service, that nobody, on the floor is going to take it seriously or really commit to changes in practice or changes in mindset or changes in the culture of the organization, which would actually result in quality. It really has to be emulated from the top. So one of the key assertions by Jurin as well as by Dunabedian and many others, I think they referred to DeFeo and a couple of the other kind of pioneers in quality assurance, are that it's that avoiding accidents before they happen, but also making sure that the consistency is there. High-performing organizations design processes and systems to meet customers' needs consistently. That they're not reactionary. They're iterative, meaning that they're constantly kind of taking the pulse of the response of the customer, but it is intentional. It's not, oh, we made a mistake, let's fix it and try again. It's more, we're going to try out a new process, and we're going to intentionally collect data on how that process played out and was received by its intended audience. And then we're going to make modifications to that process, testing each one individually so that we can isolate what works and what doesn't work and determine that there's no bias in how the interplay of factors makes that influence. So reducing variation is a really key concept in quality assurance, that you have to be able to assure that you're going to do things the same way every time. And this, plays out in terms of training of staff, in terms of orientation of staff, in terms of consistency of equipment, and how do you assure the consistency or consistent use of equipment, but making sure that your supply chains are consistent, making sure that your funding streams are consistent. All of these factors kind of go back to the importance of reducing variation. And if you can refine it to a point where you're using the same equipment to do the same processes and train the people the same way about how to implement a clinical treatment methodology, for example, that's going to result in fewer errors. You should be focused on setting some benchmark comparison points so that you have a baseline to refer back to. We've made this much change because before we started, the outcome was this, and since we've started initiating these changes, the outcome has been this and this and this, and setting a calendar for those pulse takings, if you will, those benchmark measurements, that is kind of a calendar of benchmarks that's equally spaced and on a regular schedule, and explains or accounts for other temporal events that may be impacting those outcomes. And it's just, in general, as transparent as possible is what a high-performing organization does. They're intentional. They learn from their errors, but they seek to minimize the number of defects by design. So this is one of the points that they make, and this goes back to industry. When you're talking about building a car, you should reduce variation and build quality into the product so that there's less need to depend on inspections later. Because going around and inspecting things, there's cost involved there. There's also opportunity for error. Whereas if you reduce variation and you know that you're consistently making a good product, you don't have to rely on that reactionary kind of response to an error. In quality planning, leadership is always involved, that they live the credo of the organization, that you're building measurable goals and objectives into the process before it gets out on the street, and that customer needs and expectations can be tested in real life, that you are anticipating problems before they take place, as well as customer needs and their level of satisfaction, and surveying some of that before you actually implement a change, so that you know what you're going for, you know what the goal is. Some of the other tools for quality include the Institute for Healthcare Improvement Rapid Cycle Quality Improvement Model, their Plan, Do, I would think of Plan, Do, Check, Act, but this is, sorry, I gotta look at this. PDSA is Plan, Do, Study, Act, but it's essentially the same as Plan, Do, Check, Act. This is a model that encourages little tests of change, so implementing bundles. When we talk about bundles, it means taking something that has worked and worked consistently and attaching it to something else that has worked and worked consistently, and implementing those bundles of paired or 2 or 3 or 4 or 5 interventions that taken together will make a substantive change in a process or a procedure. I'll show you an example of this when I think the next slide has an example of a way that this has been implemented. Some other quality improvement tools are use of checklists, things that we kind of think of as like, I don't even know, not academic, but things that we've come to rely on, post-it notes, mapping things, kind of concept mapping or mind mapping with post-it notes up on the wall. Use of job aids, so having kind of one of those small flip charts in your pocket that outlines, clinical procedure or a emergency protocol or something. All of these are quality improvement tools that really have only kind of came out of the quality improvement, quality assurance, and quality control movements after World War II. So we have a lot of these kind of things, to-do lists, checklists, SWOT analyses. All of these are quality improvement tools that have been borrowed from industry and applied to healthcare. The Lean Six Sigma projects, having Six Sigma as an organizational kind of training of the people who can make the biggest difference in the organization on a methodology that walks them through the steps to make a change to a process and make it in a concerted way, like all working together, has been very, very successful. And then it also kind of incentivizes people to be involved and interested, because as they take on more projects and they succeed with those projects, they're conferred belts. Go from like a green belt to a yellow belt to an orange belt to a black belt, whatever it is, the actual progression of colors. But it's a lot like, like in karate, how you're working up a series of belts to get to the status of master or expert, when you can then become the one teaching other people or leading larger projects. So it really it appeals to people because it's more than just, oh, hey, can you try out this new process with us? It's more, we see leadership in you and we see potential in you, and we're going to invest in you with these classes so that you will turn around and invest in the organization. Similar is the 6-step quality improvement process developed by Joran, and then the balanced scorecard, which is really looking at what are the key indicators that would indicate success. What are they, like, just refining down to what will fit on one piece of paper, ideally, as indicators that reflect the quality of care that's delivered to a population that's relevant to your organization. And then those are that's the dashboard of indicators that you're going to continue to track over time. So an example of one of IHI's quality improvement projects is the maternal health bundles that the Alliance for Innovation on Maternal Health initiated probably about 7 years ago now. These bundles are things that people can apply for funding to implement, but there's an obstetric care for women with opioid use disorder bundle, there's an obstetric hemorrhage bundle, safe reduction of primary cesarean birth bundle, severe hypertension in pregnancy, care for pregnant and postpartum people with substance use disorder, cardiac conditions, and obstetrical care bundle. But the intent is to address the leading known causes of preventable severe maternal morbidity and mortality in the U.S. They were funded by HRSA from, I think in Texas at the state, we started participating in the maternal hemorrhage bundle and the substance use disorder bundle and the primary cesarean birth bundles in 2015, I believe, and they were still, participating in that project in 2020 when I left. So it's a ongoing, kind of constantly expanding, like constantly incorporating new people who are being funded to implement the bundles, incorporating new hospitals, smaller hospitals in Texas was what we were trying to reach out to, because most of the smaller hospitals don't have the personnel, don't have the capacity, don't have familiarity. They don't see these cases often enough to be able to have protocols already in place to deal with them. And what this really does is walks them through development and acceptance, and making those bundles and implementation of new procedures more routine, and prepared for, so that they don't take people by surprise. Key to these, the success of these, is really having the stakeholders who have made a commitment and determined that they can contribute in terms of their time, and in terms of also their clout. A lot of it has to do with the will of an organization, and it's important to involve some of those folks who have the ability to kind of generate political influence as kind of leaders and trusted messengers of a new innovation like this. So these are 3 population-based models of care that they discuss in the chapter. And I apologize that the slides have this presentation title, like the template at the bottom, but I hope it's not too distracting for you. So 3 population-based models of care are the health and wellness model, the disease management model, and case management model. Health and wellness model, you may be familiar with this through your own insurance company through work. Oftentimes they will encourage you to do a screening or a health assessment when you first sign up for your employer-provided insurance company. And this is really because they're assuming that you're a working person, below retirement age, and that by encouraging you to take ownership and utilize these risk assessments, and then the prevention resources that they're going to serve up as a result of your risk assessment, you'll be able to, number one, be identified if you have any kind of significant risk, but secondly, you'll be taking more ownership of your wellness and health maintenance. So it's really intended to keep healthy people healthy. Disease management models, however, are typically focused on chronic disease management. So the 6 that they identify here are persistent asthma, COPD, coronary artery disease, diabetes, congestive heart failure, and depression. And it often will capture those super utilizers, folks who may have fragmented care or overutilize the emergency room, and it institutes care coordination for a specific disease. So because so many of these chronic diseases are co-occurring, it helps to have dedicated resources and optimization of care coordination across those providers that may serve one patient with multiple issues. And then finally, the case management model is really for folks with chronic conditions, but those that are high cost overutilizers of the emergency room. No medical home may be managed well on one aspect of their multiple illnesses, but not on one of the other illnesses, and therefore may be over-reliant on ER for for management of those other illnesses. And these are a small percent of the population, but they account for 60% of healthcare costs. So it's of great value to focus efforts on these folks so that they can be diverted into care coordination, prevention, and management programs. In Waterbury, for example, we have a local organization that looks at high utilizers of healthcare in our 2 hospitals and offers them community health workers to help them navigate and to better kind of dig into the resources available to them at their medical home, and keeps them kind of on track in utilizing those resources, so that they don't end up in the emergency room and then also don't end up in the hospital because they're better managing their care, but they're assisted through that process by a community health worker. Care integration is another population-based model. This is the management of multiple conditions in parallel. They give the example in the chapter about someone with behavioral health condition. That's kind of, that condition is always kind of put on the back burner while the person's physical conditions are dealt with, but really they're so tied together and very difficult to disentangle. So communication across disciplines, across the providers who are caring is key, but so is the idea of managing all of these conditions in parallel and not prioritizing physical health over mental health, because so many times mental health is what feeds the problems with physical health. It requires a medical home. It's ideally, centered in a medical home so that after discharge, there's always a constant. So no matter what the reason for the hospitalization may have been, they're always going back to this medical home that knows them and was aware of the hospitalization and was getting communication from the providers as sort of the home base. Patient-centered medical home is kind of at the center of a lot of these. The idea being that they meet patients where they are, they cater services and try and accommodate the needs of the patient, to not have the patient having to go to multiple different locations to access care. Rather, they co-locate services, communicate openly, maintain lines of communication with external referrals and external specialty providers, but they adhere to these standards set by the National Committee for Quality Assurance. And then finally, accountable care organizations, which are coordinated by Medicare, and the incentive is that when an ACO delivers high quality care and spends insurance money more wisely, the ACO will share in the savings that it achieves for Medicare. The intent of these accountable care organizations is really to look at opportunities for cost savings and reduction of medical errors, so that there's less, waste and duplication, and that, again, that there are things that we should not pay for because they are avoidable, errors and waste and poor care, and setting some of those standards as a way to encourage people to be kind of circumspect about the kind of care that they deliver. So this is an example of the National Center for Quality Assurance, patient-centered medical home, and why, what's the intent, what's the value of a patient-centered medical home. And so these are some of the kind of, enticing aspects of it, that it improves the patient's experience, improves staff satisfaction, aligns with payers. Payers acknowledge this recognition, this voluntary certification as a hallmark of high quality care. And it reduces fragmentation and better manages chronic conditions. So all of these where there's a kind of an opportunity to have oversight and resources and guidance about how to implement. That's why these quality improvement products are out there. It's a product. There's no denying that there's usually a cost involved with becoming involved with a lot of these. Not so much the ones run by the government, but others like IHI or National Quality Forum. But that there is a level of support that you're receiving from engagement with these kind of organizations, and that's very encouraging. So these are the 4 nurse-sensitive quality indicators we mentioned at the beginning of the chapter of this lecture: clinical quality, customer satisfaction, core business processes, and utilization of healthcare resources. Clinical quality meaning that we deliver consistent, reliable, predictable care, and that we focus on the issue not getting worse, certainly getting better, and that there are key measures that we can be tracking, and standard definitions and standard formula that we can look to as ways to calculate benchmarks for our movement towards quality or towards success. Customer satisfaction, things that we track with this are complaints, call center outcomes, like how quickly was a call answered, how long did people wait on the phone before they got their question answered or they got to an operator, what's the rate at which people hang up, and then surveys about customer satisfaction are a really key way of collecting data. And then core business processes. How well do we adhere to doing what we say that we're going to be doing? So these are a lot of our process indicators. Do we have job descriptions for every position, and how well did the job descriptions actually reflect what that job does or what that person in that job does? Are we doing performance reviews and performance evaluations and open communication about performance with employees? And how are we doing with productivity? How effective are our staff at doing what we've tasked them to do or asked them to do, and how satisfied are they? I think customer satisfaction goes both ways, and the satisfaction of the internal customers, so your employees, is a core business process. It's a core element of the sustainability of your employee structure. Utilization of healthcare resources. These are things like volume. How many clients are you seeing? How many patients are you able to see? It's very, challenging. It can be challenging to balance utilization and clinical quality, but how the example that they give in the book is if a nurse responding to phone calls, on a nurse hotline, is answering enough calls every hour, you have to take into account, like, if she spends too much time with one person, she's not responding to the population need. So kind of spreading that wealth across multiple callers, as opposed to just investing 25 minutes with one caller. By the same token, you can't you can't just use the number of minutes that the person spends on the phone as the indicator. You also need to look at what was conveyed, and was the person who that nurse was speaking to a high user of medical services who has now been referred into a network and pulled out of the kind of pool of high utilizers. So there's always this, they call it acuity stratification. So how well are we pulling off those high utilizers and focusing our efforts on the ones who need our help, as opposed to people who are autonomously driven to, seek out the resources that they need and get them successfully. The people who can kind of take care of themselves, we should let them take care of themselves, give them the resources to do so. But the people who need the guidance and expertise of a nurse should be the focus of our efforts. So in summary, we kind of have these two types of measures of quality: the quantitative measures. These are claims and encounters data, electronic health records, electronic medical records that generate meaningful use data, HEDIS, Joint Commission, National Quality Forum data, these big data sets generated by clinical encounters, but also that set kind of outcomes for us to track over time in order to indicate need as well as quality. And then qualitative measures, accreditation and certification. These are things that are independent pursuits. They're voluntary and indicate, they generate a lot of data because it's an introspective reflection on the organization that's going for accreditation. They throw open the curtains and say, here we are, have a look, here's how we think we're doing. And then they invite critique, and that transparency and that transparent process generates a lot of information that they can then use and learn from. And that process of going through it voluntarily is often rewarded with compensation, because if you're magnet recognized or Joint Commission recognized or any of these voluntary certifications, you can advertise that. We voluntarily said we think that we're doing a good job. Come and tell us that we're meeting the standard. We met the standard, and now you can be assured that the quality of care that you're going to receive if you come to our organization is going to be high. And they can also recruit talented staff as a result of that voluntary accreditation. Community advisory boards are really critical in population health and in the community as a way to make sure that programs are being designed to meet the needs of clients. So a community advisory board is partner organizations served by this entity. Let's say it's a hospital community advisory board. It's going to include people like the health department. It's going to include organizations in the community that are kind of gap filling or safety net organizations. But most importantly, it's going to include members of the community that are patients of that hospital, people who will be served by improved processes taking place at that hospital, and who can give feedback about their honest experience of interactions at that hospital. So that's where that's a source of data, and it's a source of value for any organization, having a touch point in the community that can give honest feedback about how well they're doing. And then provider advisory committees kind of serve the same function, but from the provider perspective are really critical in the community. So that is chapter 8. I hope that I didn't smooth over too much, but also kind of brought out some of the important elements. I have a hard time making sure that the lectures are not too long, because I could kind of just keep talking and talking, and I don't think that that's valuable to you guys. At the same time, I don't want to miss out on highlighting something that you may not, perceive as that important. So we've talked about accreditation a fair amount. So the chapter on accreditation, chapter 9, I'm not going to go too deeply into, so I'm going to pair chapter 9 and chapter 10 in a lecture that I'll be posting next weekend. And then the quiz will be available the following Friday. So I'll just make that announcement on the Blackboard announcements so that everybody's aware, and we'll go from there. I think after that, your assignment on the logic model is due. I think it's due next weekend, and after that, so we'll be pushing the quiz back, but the logic model will still be due on the date that is in the syllabus. All right, have a good evening, everybody.